What is femoroacetabular impingement? Femoroacetabular impingement is a motion-related disorder that takes place in the hip. It is a result of premature contact of the acetabulum and the proximal femoral head. When FAI is present and combined with vigorous hip motion, particularly in flexion, pain occurs. There are three types of deformities related to FAI. You have the pincer deformity, which is a focal or general overcoverage of the femoral head by the acetabulum. You have the can deformity, which is a morphology of the proximal femoral neck. And you have a combined morphology, which is a mixture of both can and pincer impingement characteristics. So FAI is actually caused by excess bone on the acetabulum or the femoral neck. This results in premature contact between the femoral neck and the acetabulum, resulting in significant stress on the labrum, which causes tearing and avulsion of the underlying cartilage tissue. The available literature of the etiology of FAI suggests that FAI is multifactorial. Intrinsic factors include repetitive athletic activity and history of paediatric hip disease and prior hip surgery. Genetic factors have previously been considered, however, there's no conclusive evidence that supports genetic transmission. Paediatric hip disease, in particular, slipped capital femoral epiphysis can alter the shape of the femoral head, which may lead to abnormal contact with the acetabulum and eventual degenerative changes, and has therefore been associated with the onset of FAI. Whereas Legg-Calvé-Perthes disease can also lead to the development of FAI. However, due to its complexity of the deformities associated with it, the radiographic diagnosis in these hips have been difficult. Similarly to FAI, bony impingement is demonstrated to be the source of pain in Legg-Calvé-Perthes disease. However, the nature of the impingement does not mimic the classic impingement characteristics as seen with FAI. As a result, the relative contribution of Legg-Calvé-Perthes disease to the development of FAI is inconclusive. FAI is primarily a chronic condition which is created by overactive osteoblast cells in the acetabulum and the femoral neck. Although during rehabilitation, exercise may result in the onset of inflammation. So I'm just going to discuss the phases of healing and say a little bit about them as I go through. The bleeding phase. A soft tissue injury is termed as acute from the initial onset and while the pain, bleeding and swelling is at its worst. It is normally cited that the interval between injury and the end of the bleeding phase is approximately 4 to 6 hours. However, this can differ between the injury and the patient. Some tissues may continue to bleed for significantly longer, albeit at a slightly reduced rate. The inflammatory phase is a rapid onset, commonly after a few hours, and swiftly increases in magnitude to its maximal reaction, which is approximately 1 to 3 days, before gradually resolving over the next couple of weeks. It can result in several outcomes, but in terms of tissue repair, it's normal and essential. The onset and resolution is swifter in more vascular tissues and slower in relatively poorly vascularized tissues. The alternative initiators of the inflammatory events include mechanical irritation, repeated minor trauma, excessive heating and cooling, plus others that may be less significant, such as infection and a wide range of autoimmune disorders. The proliferation phase. So your body does not automatically stop tissue healing at 6 weeks post-injury. The proliferation phase has a rapid onset of approximately 24 to 48 hours, but takes considerably longer to complete. It normally takes about 2 to 3 weeks post-injury. The peak in activity does not represent the time at which scar tissue production is complete, but the time phase during which the bulk of the scar material is formed. The production of a final product, which is a high quality and functional scar, is not achieved until later in the overall repair phase. In general terms, it's usually considered that proliferation runs from the first day or two post-injury through to its peak at 2 to 3 weeks and decreases thereafter through a matter of several months, typically 4 to 6 post-trauma. The remodelling phase is often overlooked in therapy and rehabilitation. It's neither swift nor reactive, but it does result in an organised quality and functional scar, which is capable of bearing a similar weight to the parent tissue, which the one that is being repaired. The modelling phase is widely quoted as starting around the same time as the peak of the proliferation phase, which is about 2 to 3 weeks post-injury. But more recent evidence would support the proposal that the remodelling phase actually starts rather earlier than this. And it would be reasonable to consider the start point would be within the first week. The final outcome of the deposition of collagen produces relatively weak fibrils with random orientation. However, with maturity, the collagen becomes more obviously orientated and in line with the local stresses. The final outcome of this, combined with the events in the damaged tissue, will be repaired with a scar which is not like for like, but does provide a functional long-term mend, which is capable of enabling quality recovery from injury.
Key bony prominences include ASIS, AIIS, sacrum, coccyx, ilium, ischium, and pubis. Posterior aspect, you have the greater trochanter, lesser trochanter, gluteal line, posterior superior iliac spine, ischial tuberosity, and trochanteric fossa. On the lateral aspect, the acetabulum. The connective tissue of the hip consists of the acetabular labrum, the articular cartilage, acetabular cartilage, the pubofemoral ligament from the pubis to the femur, the ischiofemoral ligament from the ilium to the femur, the iliofemoral ligament from the ilium to the femur, and the hip joint capsule to seal the joint space, and a bursa, which reduces friction within the joint. During flexion of the hip, the following muscles are active. Iliacus, which runs from the iliac fossa to lesser trochanter. Psoas major, which runs from transverse processes of T12 to L5 to the lesser trochanter. Rectus femoris, which runs from anterior inferior iliac spine to the tibial tuberosity. Sartorius, which runs from the anterior superior iliac spine to the pes anserine. Tensor fascia latae, which runs from the iliac crest to the anterior fibres of the iliotibial band. Glute medius, which runs from the gluteal surface of the ilium to the superior lateral portion of the greater trochanter. And glute minimus, which runs from the gluteal surface of the ilium to anterior superior greater trochanter. During hip extension, the hamstrings are involved. Bicep femoris, which originates at the ischial tuberosity and the lateral lip of the linea aspera and inserts on the head of fibula. Semimembranosus, which originates at the ischial tuberosity and inserts on the medial condyle of the tibia. Semitendinosus, which originates at the ischial tuberosity and inserts at pes anserine. Glute max, which originates at the gluteal surface of the ilium, the posterior border of the ilium, the iliac crest, the side of the coccyx, the posterior aspect of the sacrum, the upper part of the sacrotuberous ligament, and inserts on the posterior iliotibial band and the gluteal tuberosity of the femur. And adductor magnus, which originates at the femoral surface of the ischiopubis ramus and the lateral part of the inferior surface of the ischial tuberosity, and inserts at the upper part of the linea aspera and the medial supracondylar ridge. During adduction, adductor magnus adductor longus, which originates at the obturator crest and the anterior body of the pubis and inserts at the linea aspera. Adductor brevis, which originates at the lateral part of the front of the body and the inferior ramus of the pubis and inserts at the linea aspera. Gracilis, which originates at the inferior ramus and the ramus of the ischium and inserts at pes anserine. And pectineus, which originates at superior ramus of the pubis and inserts at the pectineal line. And gluteus maximus. During abduction, tensor fascia latae is involved. Gluteus minimus, which originates at the gluteal surface of the ilium and inserts at the greater trochanter. Glute medius, glute maximus, and sartorius, which originates at the anterior superior iliac spine and inserts at pes anserine. During internal rotation, the anterior fibres of glute minimus, the anterior fibres of glute medius, tensor fascia latae, iliacus, psoas major, adductor magnus, adductor longus, adductor brevis, pectineus, and gracilis are all active. During external rotation, the following muscles are involved. Piriformis, which originates at the front 2 to 4 sacral segments, ilium, and the pelvic surface of the sacrotuberous ligament, and inserts at the upper border medial side of greater trochanter. Obturator externus, which originates at the pubis and ischium and the outer surface of the obturator membrane, but inserts at the trochanteric fossa. Obturator internus, which originates at the internal surface of the obturator membrane and the surrounding bony margins, and inserts at the medial surface of greater trochanter. Gemellus superior, which originates at the gluteal surface of the ischial spine and inserts on the tendon of the obturator internus and greater trochanter. And gemellus inferior, which originates at the ischial tuberosity and inserts at the quadratus tubercle. Gluteus maximus and quadratus femoris was also involved, which originates at the ischial tuberosity and the acetabulum and inserts at the quadrate tubercle and halfway down the intertrochanteric crest. Glute medius, psoas major, and iliacus and sartorius are also involved.
FAI presents as anterior or anterolateral hip pain that refers to the groin and occasionally radiates down the anterior thigh. To exclude any lumbar pathology, we ask the client to complete a lumbar flexion, lumbar extension, side flexion on both sides,
the other side. So walk like this and then flip it over in one shot. From the other side and then
and a quadrate, which is a extension with rotation to both sides. As such. The client will then perform the Trendelenburg test. The Trendelenburg test allows the clinician to determine any glute med weakness. In addition to this, the weight shift test can also be performed, which is as simple as observing the client to see whether the weight is on one particular side more so than the other. There are two tests to conduct by a client. The Ellis test and the Craig's test. So, the Craig's test measures the Q angle. And the Ellis test measures range of motion for the rec vec.
So it's
While the client is laying supine, you can conduct a straight leg raise,
right. So jumper's knee. It's tended. There's tenderness
Faber's
during
test.
palpation, but when the knee is extended, that is when it's more tender due
And
to
Faber's
the cord being
test.
relaxed. Jumper's knee is a weakness of the patellar tendon.
Most effective treatment for FAI is considered to be exercise restriction. However, to assist rehabilitation, soft tissue, joint mobilisation and stretching should be prescribed to accompany.
Because I feel so that shows what most of us have done with them, but then hardly any of them came in.
It's ready for improvement for uses and don't turn up anymore.
And then we need SNC stuff, what they've been doing SNC, but at the end, because of Rochelle, they've been handed off to the other two, Gemma and what's his name, Joseph? Jonas. Joseph. It started in the J, I was close. And they've not really given us any.
Treatment modalities for FAI have been conflicting. Evidence suggests that exercise therapy is an effective conservative treatment. However, in most cases, surgery is more effective. If solely using conservative treatment, then the aim of exercise rehabilitation should be to strengthen the deep hip muscles, improve by using functional lower limb exercises, and improve mobility and the postural muscles. If the client is being treated by purely conservative means, then the aim of exercise rehabilitation is to strengthen the deep hip muscles whilst providing stability and improving postural control. Dr. Kelly et al. Recommends hip strengthening and functional lower body exercises, hip strengthening, core stability and postural balance exercises.
Phase 1 of the non-operative rehabilitation for FAI consists of the side-lying clam, side-lying abduction, donkey kicks and glute bridge. Each of these exercises is to be performed in 3 sets of 20 repetitions and aims to reduce the pain surrounding the hip and increase glute activation as witnessed during the Trendelenburg test. It should be noted that the client should not be progressed until phase 2 until exercises are being performed perfectly and pain is not present. Phase 2 of non-operative rehabilitation consists of standing abduction, banded lateral walks, single leg Romanian deadlift, banded sumo squats, and a double leg glute bridge. Phase 2 aims to incorporate weight-bearing exercise and increases core stability required to complete the exercises. Each exercise is to be performed for 3 sets of 15 repetitions. Similarly to phase 1, the client should not be progressed on to phase 3 whilst there is pain during exercise or exercises are being completed incorrectly. Phase 3 is the final phase for Femoroacetabular Impingement rehabilitation. It incorporates weighted and unstable exercises, further increasing the core stability and strength required to complete them. In this phase, each exercise is performed in 3 sets of 8 to 10 repetitions. As previously mentioned, stretching should be incorporated throughout phase 1, phase 2 and phase 3. The following hip complex of glute/piriformis stretch, kneeling hip flexor, prone quadriceps stretch, and quadruped adductor stretch should be incorporated, and each stretch held for 3 lots of 30 to 60 seconds.